I thought when I became a women's health nurse practitioner that I would love the OB with its prenatal care and anticipation, and that I would hate the GYN, or the gynecology. The OB part ended up being so very repetitive, and the young adolescents whom I served needed so much educational support that I ended up actually enjoying the gynecology more. There was little repetition. You never knew what the problem would be when someone called for a GYN appointment. One day a teenage girl called to make an appointment. "And what will the clinic visit be for?" asked the medical assistant. I have a stick in my back," replied the patient. The medical assistant called me to the front office to take the call because it seemed so unusual. The patient was clearly uncomfortable talking about it. She repeated that she had a stick in her back. I told her if she had any sort of a spinal injury, she should go immediately to the ER. No, she says, "it's not like that. You're the one I need to see." We managed to get her in the next day. Her mother came with her, and that was a very good thing. I'm not sure I would ever have found out what the real problem was if I had had to rely on her description and unwillingness to allow me to see the problem area. She had a large hemorrhoid. Women are just as reluctant, or more so, to discuss sexually transmitted infections. Our society somehow considers it to be a moral failing for women to be promiscuous, though a promiscuous man is often considered virile or cosmopolitan. All pregnant women and all annual GYN exams include a sexually transmitted infection panel, which is HIV, hepatitis B, RPR, which is for syphilis, cervical cultures for chlamydia and gonorrhea, a wet prep for trichomonas, and yeast and bacterial vaginosis while we're at it, though those usually are not considered sexually transmitted infections. Visual inspection of the vulva may reveal the presence of condyloma from human papillomavirus, though it is unlikely since most forms of human papillomavirus leave no visible trace of their existence. If the patient is having a herpes outbreak, this can be visualized, but it is always heralded by acute pain, and that is usually the presenting complaint rather than simply an annual exam. Usually, of course, all of these exams come back negative. But when they do come back positive, the clinician must report the reportable infections to the health department via an official form. The client must be informed. Most clinics have policies to the effect that sexually transmitted disease notification must be given face-to-face. We would not want a patient with positive HIV status to commit suicide, for instance, nor would we want to give a result over the phone to someone who claims to be the patient but is not. So the patient returns to the clinic because we have told them over the phone that we need to discuss the results with them. They're usually a bit worried. I have had many girls that have just become sexually active sitting in my office awaiting their results. Sometimes the boyfriend or husband is with them, and I give them the choice to speak with me alone before we even go into the office. Usually, however, they want the man there for support. I give them the news, and usually it is chlamydia. I explain that it is a sexually transmitted infection. Some women react calmly, and it has been the policy that the man and woman may both receive prescriptions for this, which is actually the only thing for which a women's health nurse practitioner can treat a man. One young girl said, "Well, it must be wrong because I've only had sex with one man and it's him, so I can't have a sexually transmitted disease." She pointed to her boyfriend, and he was, by this time, looking away, staring up at the ceiling. And I would tell her the test is quite conclusive. It's very reliable. And when I did the exam, the appearance of the mucus in your cervix did appear to be the sort that we see when chlamydia is present. "But it can't be," she would say, and suddenly, as the truth of the situation dawned upon her, she started crying and shouting and slapping her boyfriend on the head and face. He looked sheepish and held her hands firmly to prevent further hitting. I gave them instructions and prescriptions, and they quickly left. Usually the notifications were not so dramatic. One day we had a case of chlamydia in a newly pregnant woman. Her husband was there, and this particular day the physician was also there and said he would take care of talking with him. The woman came out of the room a few minutes later with a tear-stained face, but the doctor remained in the office speaking with the husband. I could hear raised voices, and soon the two of them stormed out and the couple left. My point is that infections in any other context do not often cause emotional, psychological, and marital pain. Human sexuality is not just a branch of physiology. It is inextricably linked with our deepest feelings and our self-concepts and self-image. Many women in my office with a sexually transmitted infection displayed the merest sign of impatience that now they would need to shell out money for an antibiotic. But it seemed not in any way to be linked with emotional pain for them. Every situation, though, is different. Practicing as a women's health nurse practitioner freed me in many ways. I learned to simply take each individual as they were and deal with the situation at hand. I separated my own conventions and morality from how I treated them. It is always right to advise patients to safer practices, and that is an integral part of nursing, but the patient herself is the one who determines what she will do about it. I care for her no matter what choices she makes, and if she comes back to the clinic in a month with the same sexually transmitted infection, we start all over, and I continue to be her clinician. I found out a long time ago that the world doesn't revolve around what I think is right or wrong, and that I must care for each patient the best way I can, seeking their health and moving from their current health status to where they and I together want them to reach. Note the box on page 175 identifying the sexually transmitted infections. In general, remember that we can treat and cure all of the STIs except the viral STIs, or sexually transmitted infections. Resistant varieties of some of these others are beginning to emerge, so we may not be able to cure all of them for long, unfortunately. You will need to know the manifestations of each one of the STIs, though you do not have to memorize all of the treatments and dosages. I would have some general idea of the treatment, however. For instance, that penicillin is always the treatment for syphilis. Remember that when you treat a pregnant woman, the fetus is also being dosed. Some medications are not appropriate for pregnant women, and so we have to use something different to treat the disease, something that may not be as efficacious, but that is safe for the baby. So what is the most common STI? Without doubt, that would be human papillomavirus, or HPV. An authority in women's health, Sherry Carter from UT Southwestern, told us in a class that if a woman has had sexual relations with two people, or if her partner has, she has been exposed to HPV. That includes just about everyone. HPV is extremely contagious. A healthy immune system can eventually clear this virus from the system. It does seem, however, to get worse during pregnancy due to immune system changes. And if there are visible warts, they can exacerbate to the point that a vaginal delivery is not possible because of the sheer amount of space they consume, though that is rare. There are at least 100 serotypes of this disease, and only about 5 of them cause visible warts. About 8 of the serotypes of HPV can cause cervical cancer, and in fact are the primary cause of it. The most common of the bacterial STIs is chlamydia. I had thought when I went into women's health that I would see all of the STIs on the list on page 175. In reality, I saw lots of cases of chlamydia, a few cases of gonorrhea, herpes, and trichomonas. Note that group B strep is tested in pregnancy, but it is common flora for many women and is usually not a sexually transmitted infection, and it is very common. I never did get to see syphilis in my own practice except as a clinical student at the Dallas County Health Department. Small town USA really doesn't get many of the more exotic diseases, and I practiced in a very small town on the Texas-Mexico border. So which STI hurts the most? Herpes? Every time. Every time I got a call from a girl saying, "It just hurts so much," it turned out to be herpes simplex. Type 2 is mentioned as the genital sort of herpes, but herpes is not particular. Type 1 is quite content to grow on the genitalia. The worst case I ever saw with at least 20 lesions and which was causing a lot of pain to the young girl was type 1. In our discussion of how it is transmitted, she denied sexual activity with anyone other than her boyfriend who was with her. He did not and never had genital herpes. I could tell she was telling the truth when denying promiscuous sexual activity. As I was explaining the use of acyclovir, I happened to glance up at the boyfriend and noticed for the first time a large herpes cold sore on his lower lip, which proved to be the source of the infection for the girl. It is important to know that many of the STIs, particularly chlamydia and gonorrhea, may have no symptoms at all at first. A few months can go by without any noticeable change in vaginal secretions or pelvic pain. But sometimes there are manifestations relatively soon after infection, including increased pain with menses or purulent cervical discharge. Of course, either of these infections can lead to generalized pelvic infection known as pelvic inflammatory disease or PID. Every case truly is different. Most of the women I diagnosed had come in for pregnancy or annual exams, and not because they had suspicions that they had an STI. The torch infections frequently show up on standardized tests, so make sure you know them. You have already studied the sexually transmitted diseases and prevention for those in health promotions, so we won't duplicate that. What you need to learn from this chapter is the STIs and other infections like torch and how they relate to pregnancy. The table on page 179 in the book is quite helpful. Most women have BV at some time, since it is not necessarily sexually transmitted, and it may be just an overgrowth of the normal indigenous bacteria. But we believe it can cause preterm labor and birth. Page 194. Perhaps the bacteria involved actually weaken the membranes that surround the baby and cause preterm rupture. Or maybe toxins produced by the bacteria stimulate prostaglandin production and initiate contractions. We don't know. Trichomonas vaginalis is a one-cell protozoa that is almost always sexually transmitted, though not every single time. It is easy to see under a microscope. It bebops and gyrates and vibrates, while most of the other cells that you're looking at under the microscope are very still. It can live in a male or female body for a long time without very many symptoms, and we do treat it during pregnancy. Group B strep turns out to be a very big problem. We treat it in pregnancy. Most of us test by doing a vaginal culture on admission, and if it's positive, we treat with a course of oral antibiotics. We retest again at 36 weeks and treat again if it's present. Then when the woman goes into labor, we give IV antibiotics while she's in labor. All of this to prevent the baby getting it, because it can cause neonatal sepsis or respiratory infections and maternal fever. All from a bacteria that is truly a part of the normal flora in the non-pregnant women, present in 9 to 23% of pregnant women, and that would be from page 197. What if a woman is attended by a midwife and is group B strep positive? What happens then? They test for this. Professional midwives will send a woman to a physician for a prescription. Certified nurse midwives, of course, are advanced practice nurses, and they can prescribe the necessary medications in inpatient and outpatient settings. Whenever I go down to donate blood, I notice that they mark my blood CMV positive, cytomegalovirus. 60% of the adult population in the U.S. is CMV positive. When I was a PDICU nurse early in my career, I cared for many cases of neonatal cytomegalovirus, some of which were very sad. I imagine that sometime during that period, I contracted CMV. We want to prevent women getting their primary infection with CMV during pregnancy because it can affect the fetus profoundly, though the mother herself may show no symptoms at all.